This program is intended to be general in nature and should not be used as a substitute for advice from a qualified health provider.
On Health Matters Television for Life, living with Alzheimer's disease.
He got to the place where he couldn't finish projects.
A Spokane man with a family history learns he has Alzheimer's.
I became suspicious early on, realizing that complexity of things was beginning to be a problem for me.
A husband and wife share their journey.
It's moment by moment.
Alzheimer's, right now on Health Matters.
Health Matters is made possible by our viewers, the friends of KSPS, and by Providence Healthcare.
I'm Arnie Peterson, and I'm an orthopedic surgeon, and I work at Sacred Heart for Providence Medical Group. When I needed my hip replaced, I chose Providence because of the professionalism and the care that I knew I'd receive. I never thought twice about going anywhere else.
My name is Beth Torres, and I am a registered nurse, and I work at Holy Family Hospital on the labor and delivery unit. I'm about to have my second child, and I chose Providence because I love and trust the people that I work with, and why wouldn't I seek care from people that I love and trust?
And welcome to another edition of Health Matters. I'm Teresa Lukens. Alzheimer's disease is the most common cause of dementia, affecting more than 5 million Americans. Families coping with Alzheimer's in a loved one describe it as a long goodbye. Here to help us understand this very complicated disease, our panel. Naomi Chaytor is a board-certified neuropsychologist, researcher, and a member of the faculty at the Elson S. Floyd College of Medicine at WSU. Barbara Baehr is a registered nurse with Providence Adult Day Health. Dr. Stephen Grossman is the Assistant Dean of Outreach and Career Development at the Elson S. Floyd College of Medicine. He has a background in palliative care and hospice. Joel Loicono is with the Alzheimer's Association. He has been for 20 years. He is currently serving as the Regional Director for Eastern Washington and Northern Idaho. And I want to welcome all of you for being here. And Joel, I think I said your last name incorrectly.
You did just fine.
I want to make sure I get that correct. We are streaming this program live tonight on Facebook. We also welcome your emails and your phone calls. It's a chance to really tap into this expertise that we have on our panel tonight. So let's begin at the beginning, I guess. What we know about Alzheimer's is that it's terminal. It is progressive, and it slowly steals a person's mind, and eventually people will die from it. It is increasing. By the year 2050, I believe, we said 5 million Americans right now, but by that time, in the next 20 to 30 years, that number will increase 14 to 16 million. It's a lot of people. So what do we know about this disease, Dr. Grossman?
Well, we know it sneaks up on patients, and it sneaks up on their families. It takes some of the vitality away from their lives. We often ascribe the changes that they go through as normal aging, but sometimes it's way beyond that. And we really need the collective advice of the family or loved ones, people who are close to the individual, to help us make a diagnosis early. We need to look at their overall health, and that's what primary care doctors and family doctors do a lot of, so that we're controlling the other kinds of things that might interfere with their mentation. We want to make sure medications are not a problem, and their blood pressure or their diabetic situation is well controlled. And then we use a team. We have to do this collectively to look at the individual and look at their environment and look at the pros and cons. And then we have to have some conversation as early as we can about what the individual wants in their life. What kind of care may they want if their memory is failing or their inability to function on their own? What would they like? What are their advanced directives? What kind of a living will might they put together?
Mm-hmm. So it begins usually with the primary care doctor?
It often does. And as we were discussing earlier, it can be so masked that if you're having a conversation with the individual involved, they would say everything is fine. Barbara, how are you doing? Oh, it's good. How's your memory? Oh, my memory's fine. You know, I'm forgetful, but so we don't even recognize the loss of function without others who can help showcase what's going on.
Well, in fact, then you need to differentiate between what is normal aging and some memory loss that comes along with that, and indeed what is Alzheimer's or some other serious dementia.
Right, and
I think that that's such an important distinction. So everybody kind of thinks about as they get older, they're going to have more trouble with their memory, forget birthdays, that kind of thing. And a certain amount of that is normal as we get older. And it's important to bring your concerns to your doctor, though, so that differences that might end up being more reflective of a pathological process of Alzheimer's or another form of dementia can get detected soon. And some of the ways that we do that are by actually testing people's memory. And that's where I would come in as a clinician. I would interview somebody, get a sense of the background. When did these problems start? What else is going on? Ruling out other potential problems that can cause memory loss or other cognitive changes. And then do a battery of tests. And this can be simple screening tests that you might do in a primary care visit, or much more detailed and complicated tests to get at more subtle changes. And what we do is we compare that performance to other people your same age, education level, so we can get a sense, is this different from where we'd expect for you? And then even if that comes out normal, we then have a baseline level of performance to track people over time, so that if those changes are more than we would expect for aging, we'd be able to detect that really early. So going to your primary care doctor, getting that sort of baseline screening test to see that your thinking is okay right now, and then tracking it over time.
Mm-hmm. And Joel, having worked for a number of years with patients and around patients, can people be quite resistant to even beginning the testing process?
Yes, because they're afraid, or their family are afraid. Many times they know they're losing capabilities, and that's hard for us to acknowledge that. They're afraid it might be Alzheimer's, and that's why I agree with our two doctors that it's important to get in and find out what it really is, because we don't know what it is until you get into the physician. It might be something that we can turn around. And what if it's a shame if it is something that is reversible? Plus, the other thing is if it is Alzheimer's, that you need that time to prepare yourself, your family, and there are a lot of things that if you don't want to procrastinate on. If you take care of now, planning now, it leaves you with many more options down the road. The other thing I want to point out is Alzheimer's is not just a senior disease. There are 200 to 300,000 people in the U.S. who are under the age of 65 with Alzheimer's disease. I've had people in their 40s with children in grade school and middle school in my office. So, and I also want to point out that the disease is, there are early stages to this. And a lot of times people just think it's all about the middle and the late stages, but there are people in the early stages who have a life to live, and really throughout all the disease, you have a life to live, and you know, just want to point that out as well.
Mm-hmm. And that's an excellent point. So before the diagnosis of Alzheimer's, we're learning more about what happens earlier, because the way to prevent it is to identify people before they even develop the disease. So a newer diagnosis is called mild cognitive impairment, or MCI. And having this diagnosis will put you at increased risk of developing Alzheimer's, so you can be tracked and watched over time, but not everybody will develop the disease. What it is difficulty in one cognitive area, usually memory, but otherwise you're doing okay. So your functioning is good, your other areas of cognitive functioning are good, and that condition there are some treatments for. So there is pretty good evidence that exercise can help slow or prevent further cognitive decline in people who have mild cognitive impairment, and also some types of cognitive training, and this is very loosely defined, and a lot of it is what we would do in our normal everyday lives anyway. So increasing your activity level, social activities, being engaged in things that interest you. And there are no medications per se that can prevent decline to Alzheimer's disease, but there's a lot of research going on to try to find new treatments, and that's where it's going to have the biggest impact and to benefit people is before the disease starts.
And Barbara, that's where you come in. You work daily with people, keeping them active and that have Alzheimer's disease.
Right. I would just give a little background in our program at the Adult Day Center in that there is exercise, 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 and specific groups for cognitive improvement. Yes, right, that's correct.
Mm-hmm.
Yeah.
And what kind of improvements do you see in people that are moving more or doing puzzles and those sort of things that may help?
I don't know that I would say necessarily there's an improvement, but ideally a maintenance. It's a way, because of the way we're set up, that we can work with families, work with physicians, so that the family can better deal with the person that they have at home, can provide supportive help to them.
Well,
so
it's the quality of the life of the individual.
Right, exactly.
And nurture, I'm sure most of what you do, or a lot of what you do, is nurture the family in terms of what their expectations are, how they can support their loved one, avoid confrontation.
Yeah, those are some of the things like the staff tries to model those kinds of things. I was thinking the other day, we had a little woman, and for some reason after lunch, she's ready to go home. And she's saying, oh, I am going home. And where do you go with this situation that could escalate? And there was another one of our ladies getting ready for, actually it was an exercise program. And I said, oh, come with me. I said, we were waiting for you to come over and sit down and join us. And so there was a way to, you know, redirect her from where she was going, not really build up the tension, the anxiety, and she became engaged in that activity. So there's the redirecting is a big important part of it, yes.
And something so simple that could escalate into the wrong thing.
Exactly.
Well, and that can become a big frustration for families and caregivers because it's just frustrating for them and they may lose their patience with their loved one.
Well, and that's why these types of programs are so important that they need to remain socially engaged. If their day is comprised of sitting in front of the television all day, symptomatically they're going to decline faster than if they remain socially active and spiritually active as well in programs like what Barbara's talking about. So activities are an important part of quality of life, but also when you're talking about behaviors, many of the behaviors come out of their feeling of they don't have self-worth anymore, that they're having problems doing things, and so a lot of this is generated out of the behaviors are generated out of emotional needs that are going unmet. That programs like Adult Day help to do. So it's worthwhile to take time and participate in programs like that, and to take classes for caregivers, care partners, to take classes around how to be a caregiver for a person with any type of dementia.
They provide great respite for the family.
Absolutely.
Because as the book you were carrying depicted, there's a 36-hour day, and everybody needs a break from that to be able to be refreshed and come back to their loved one and be renewed. And
what can a patient, Dr. Chaytor, every case is going to be unique and different, but you mentioned the stages, those phases. Talk more about that and what a patient and the family can expect within those different phases.
Right, and so early on, so at the mild cognitive impairment stage, the individual will usually be well aware of the memory problems, so they will notice them. They may not be forthcoming about them, so it may be a loved one that's noticed it. But usually there will be more awareness at that stage. As the disease progresses and more cognitive functions become impaired, so starts out with memory, then the actual diagnosis of a dementia requires cognitive impairment in two areas. So usually for Alzheimer's, it's memory plus another area like visual spatial skills, word finding, language skills, or decision making, planning.
Plus, you have to have some problems with everyday functioning to get that diagnosis. Things like cooking, financial management, driving a car. And once you have those two pieces, then you meet criteria for a dementia. And that's where you start seeing more of the problems with daily life. The interesting thing that will happen as the disease progresses, the individual themselves will often start to lose insight into their problems. So they may become actually less concerned, whereas the family is becoming more aware of the problems, and it's becoming more disruptive to the rest of the family. So it's one of the things I always would say to patients is that at least in moderate dementia, that it's often way more distressing to the family than it is to the patient. And the family will spend a lot of times worrying about what it's like to be the patient, but they're imagining themselves and with full awareness. And I think it can be sometimes reassuring to know that it's not that way for the patient, that they actually don't have the same experience as the disease progresses.
So you need to have the important conversations, the tough conversations.
The tough conversations.
Right out of the chutes.
You do,
yes.
and you don't just hop in and say, well, let's talk about what mom would want if mom ended up in the hospital on a ventilator. But you begin to couch the conversation, tell me about your loved one, tell me about grandma, mom, whoever it might be, and involve the individual early on in that conversation. So have you had any experience with friends or other relatives who may have ended up in the hospital and been confronted with, a serious illness, and what would they want? Have you thought about what you might want for yourself if, you needed dialysis, or perhaps you needed to be on a breathing machine because you've developed pneumonia after the flu and it's gotten very progressive? So you can begin to engage in those conversations early and try to map out what the individual may want. And what they want today may change in a month or 6 months or a year, but at least you've begun to have the conversation. And then the family begins to understand. We pick someone who can speak for this individual, who knows the wishes of the patient, a durable power of attorney, someone who can voice the opinion of the individual when they can no longer speak for themselves. And then we can involve the physician in terms of putting down some medical orders, perhaps. I would not want a feeding tube, or I would want to do this or that. And so those ideas can be formalized in case something happens. And it's difficult because you don't want to say, well, grandma, if you were to have a heart attack tomorrow, what would you want? Well, you've got to begin these conversations very delicately. And they can begin early on in a conversation, especially with a primary care doctor who would know the individual. They can begin to broach those. And then, so often what happens is you're in the emergency room or you're outside of intensive care where the conversation begins, and of course that's the wrong place for it. I mean, it's a necessity then, but it's not the appropriate option.
So while it may be difficult, you definitely need to have it early.
Yes.
Yeah.
So there are classes available for people in the early stages with memory loss or the MCI, mild cognitive impairment, or the early stages, and their caregivers who we take them through those kinds of discussions. We partnered with other agencies here in the state of Washington, and we're also providing a program called Staying Connected, which is a 4-week course. They meet once a week. A person with memory loss or early stages of Alzheimer's or any type of dementia and their care partners, and it's a combination of education and support group. There are support groups for people with memory loss and early stages of Alzheimer's just for those folks. There are also caregiver support groups as well, and those caregiver support groups are really good places to go and to pick up practical tips, bounce ideas off of people, and be able to relieve some stress without being judged by people who really don't understand what this disease is all about. And the care partners need to take care of themselves, and that's important. As we tell people, it's just like when you're on an airplane, they tell you to put the mask on yourself before you put the mask on your child, because we do lose people, care partners, before we lose the person with dementia from stress-related illnesses, and being as you said, having to go through the 36-hour day.
And I think it's important, I mean, talking about planning for the future, even before some of the medical decisions need to be discussed. Things like what will happen if my partner can no longer take care of me, or that partner is working and they need some supervision during the day. And usually, you know, when I would see people early on with the diagnosis is that they didn't have a lot of medical problems, so they were physically healthy, but they may be at risk if they're at home alone with a stove, or remembering to take medications, or if someone were to come to the door and try to sell them something, being able to be critical thinkers in that situation. So often it's earlier than that, is there somebody that can come check on this person?
Right. Where would you live
if
you were alone and you couldn't function alone? And
getting family members.
Not being able to drive anymore and so forth. So you're absolutely right. So even before that, it's just the practical, how to deal with the activities of daily living.
Right. Yeah. And I would often see people when there was a problem. So they were living in their home alone, and it became to people's attention because they fell and broke a hip and were in the hospital, and it became clear that they were having problems with memory or other thinking skills. And there was no plan. And then it became, you have to now leave your home. You've got this diagnosis. You have to now go into an unfamiliar setting. And that's really scary for people. And so having this discussion, you know, earlier in life, even if there's no concerns about memory, but what would I want? Would I want to live in assisted living? Would I want to stay at home no matter what and have someone come into the home? Just really thinking about that plan and having it set up early.
Well, it's one thing to know that Alzheimer's runs in your family. It is quite another to actually face it. A Spokane man is doing just that, but he's not doing it alone. Tonight, the journey that he's traveling with his wife and why he says he still has hope.
Dot Symes says she knew Dave was the one for her the first time she saw him in the hospital cafeteria where she worked. Dave was saying grace before a meal.
He doesn't even know anybody's watching. And I thought, that's a good man.
Soon, they'll celebrate their golden wedding anniversary.
50 years next year.
The couple's been through a lot in almost 50 years.
Dave's dad had Alzheimer's.
It became obvious that he was having difficulty dealing with everyday things.
A few years ago, Dot started seeing the signs again, this time in Dave.
He got to the place where he couldn't finish projects. And he came home and told me, something's wrong.
Because I was aware of it, I became suspicious early on, realizing that complexity of things was beginning to be a problem for me.
Like his dad, Dave has Alzheimer's. For now, the couple copes.
Mostly it's short-term memory. When he gets up in the morning, I have a book and I have written in the book everything that we do for a certain day.
They're open about Dave's health, but early on they kept it a secret.
I began to reach a point where I felt that my Alzheimer's was going to become obvious to some people. And so at that point I began to share much more openly.
Dave and Dot attend a support group sponsored by the Alzheimer's Association. It gives them strength.
We encourage one another, we spend time together enjoying who we are, where we are. And that's become an important part of my life.
So does their faith, which is a constant source of hope.
We know Jesus Christ as our personal Savior. And that's the best relationship we have ever entered into, ever. And most important, we will see Him when we die. And Dave will have a mind that is completely perfect.
I accept Him as my Savior. I will be in His presence for all of eternity. And there won't be Alzheimer's.
As the disease progresses, the couple does their best to take it day by day.
That's what you have to do. It's moment by moment.
I hope so.
If they've learned one thing, Dot says it's to ask for help.
You are not alone. There are people traveling this same road. Let them help you.
Well, and Dave is currently in a clinical drug trial. The couple says their hope is that the study will lead to a cure in their daughter's lifetime. And Joel, you know the couple. You're familiar with them. A lot to be said about that story, their faith, the fact that they knew that they needed to ask for help, but also I was interested in the fact that they said they didn't want to tell people initially. Is that common?
Yes, you know, there still is that stigma, and that's one of the things that we're working on is to get rid of that stigma. Yeah, you know, this is a disease that is not your fault. And many people have it. A lot of times people think that they're the only ones, and you know, that's where the support groups come in to find out, hey, I'm not. And you know what, doggone, I'm doing a good job. I'm doing the things that I need to do. So, yeah, it's sometimes something we kind of still talk about like we used to with cancer, with a hushed voice. But you know what? I liked what Dot said, which is you need to talk to people about it. You need to seek friends, help from friends, people in your church, community services like the Alzheimer's Association. You've got a tiger by the tail that if you don't get help, this tiger will eat you alive. Not only the care partner, but also the person. And you know, the person with any type of dementia in the early stages needs the opportunity to talk to others and to socialize, because sometimes what happens over time is they'll lose their social connections because people don't know. They know they have Alzheimer's, but they don't know how to handle it. They don't know what to say. And a lot of times with, you know, with the memory cafes that we have and other early stage programs, they can talk to other people about this.
Okay. And people will avoid those social situations because they're worried that they could make a mistake and be found out. So if you tell people, you can kind of remove that, right? And that they can help support you in those conversations. Instead of asking you a question that you might not remember, they can kind of move the conversation along. And one of the things of the video that they touched on a little bit that I think it's important to mention is the strategies that they were using. She mentioned a book that she writes everything down. And especially early on, people can compensate for those memory problems pretty effectively if they get some training and get support from family members. There are ways that, you know, I use a calendar, I use a planner. I don't remember my schedule unless I look at it, and it's the same principle. And then later on, structure in your day can do a lot to avoid problems.
Having a real routine.
Exactly, exactly.
Routine is your friend.
Right, and this is all understanding the way the brain works, and that if we have a habit, it's less about that decision making, that higher level cognitive functioning. We just sort of go through our day the way we went through our day yesterday. So any change to that routine can be really difficult for patients. Going traveling, you know, having family, like a party or anything out of the ordinary, which may seem like fun, can lead to more difficulty. Yeah.
And Barbara, do you see that?
I do, and I also want to respond too. There is the routine that's important, but it's not absolute. I would give the story of someone whose shower day was today, let's say, and they did not want to take the shower, you know, and again, there's that tension building up there. I'm weighing how important is that shower to take today or at this time? Can we adjust it a little bit? But the overall routine is there, but it's making choices, judgments by the caregiver of what needs to be maintained for safety issues, and then what can I just let go of. Nothing will happen, you know, catastrophically. This person will still get the care they need.
Yeah, the so what factor.
Yeah.
So what if they don't?
Exactly, exactly.
When patients have chronic illnesses, and certainly dementia is one of those, they lose control. I mean, we all think that we know where we're going to be tomorrow and next week and so forth. But now all of a sudden the disease has taken hold. And so sometimes they need to make those decisions about simple things. I don't want to take a shower. I can't control my disease. I can't control the loss of my memory. I can't control the fact that my spouse has passed away. But I can control my decision to eat, to not eat, to bathe, to not bathe. And so sometimes we need to allow them to make those decisions, despite the routine that would help them have a pattern to their life. They can decide not to.
Well, give them choices.
Give them choices, and not a whole bunch of choices, but maybe a couple of choices.
Not overwhelming. Yes, absolutely.
Something that was also mentioned in our story with Dave was that his father had Alzheimer's, and that they were concerned about their daughter. How concerned should they be?
And this is definitely a common concern that people will, and I think become more aware of their own memory as they age, because I would often hear, you know, I'm worried because my mother had Alzheimer's or a family member. And the vast majority of cases of Alzheimer's are not directly genetically related. So there is a form of Alzheimer's, and Joel had mentioned, you know, younger onset individuals with Alzheimer's, they tend to be more of the familial or genetic forms of Alzheimer's. But the majority, it's not genetic, and it's probably a combination of some, you know, genetic factors, but it's complicated. And then there's environmental factors, and we're learning more and more about different risk factors for Alzheimer's. There are some genotypes that put you at increased risk. There's other health variables that are very important in terms of vascular risk factors like diabetes, heart disease, hypertension that can increase your risk of Alzheimer's and other forms of dementia. And then having more education, interestingly, can be a protective factor. And when people do get dementia, it will often be later. So there's an idea that there's a reserve, a cognitive reserve or brain reserve that can buffer against that decline.
Well, and in fact, that goes to an email that we received from Betty in Coeur d'Alene. She says, besides memory loss, are there any other warning signs of Alzheimer's disease?
Sure. Changes in judgment. Changes in mood and personality.
And what kind of things might you notice, Joel?
Well, all of a sudden where you had somebody who was very involved in their grandkids, and now they're not asking any questions about the grandkids. All of a sudden where you had somebody who, say, maybe worked in a bank and kept their checkbook immaculately, and now all of a sudden their checkbook is hopelessly out of date. Or
so very uncharacteristic as to who the person you know.
And it's not just one thing. It's really many different things that you see, but sometimes we're just, as family members, and I know this from personal experience, that you're going, well, geez, is this really something I need to worry about? Is this, or is this just mom's getting older? The symptoms are much more profound than normal aging. You know, when you start to see the keys go into the freezer instead of on the counter, the symptoms of dementia rob you of your ability to live independently, and it's very insidious in its onset. But we, as family members, we really need to be observant and kind of look and make sure that we're not kind of, I don't want to see this, and so it's not that bad, or sometimes we make excuses for some of the things that were happening, and then when we sit down and talk with people, we go, oh my gosh, Mom actually had Alzheimer's disease years before.
And partners can create an alibi for their loved one. Oh, Joel never remembers anything about the season. Yes, he never had a good memory. But then we also have to be certain that we've not missed a medical diagnosis. Depression, for instance, often creates a withdrawn state, or apathy, a loss of involvement in the things that they had interest in before. And that's an important reason to check with their primary care doctors to make sure that there isn't something, as we talked about earlier.
Diabetes, for example.
Diabetes that's out of control,
failure,
congestive heart failure,
Yeah.
a high blood pressure that's not well controlled, cholesterol that's up, a whole host of things that also need to be managed for their collective well-being. You know, we've begun to teach our students how to deliver bad news. We have a course in art and practice of medicine, and we've role modeled in our simulation center and places and other places where they've had to confront certain, their classmates on how to ask these questions and how to deal with the answers and how to be at a loss for words, because these are things that we can teach and are learned. None of us come into those situations easily. We don't have end-of-life conversations very well or very easily, but the more we do it, the more comfortable we are. And so we're trying to role model and teach our students early to be comfortable with delivering bad news or having difficult conversations.
And I just wanted to add to the question about other kind of cognitive things that can happen early on. One of the other more common early cognitive signs is a visual spatial difficulty. So sometimes people will get disoriented or sort of confused as to where they are, sort of get lost. And it will often initially happen just briefly, and then they're reoriented later. But there's sort of this pattern that will develop more and more over time. So it will be progressive. I would often, the people that would come in that it would end up being sort of the normal aging process, it was often like one or two isolated instances, and maybe they hadn't slept well the night before. There was some explanation for it, and that's very different. What we're talking about is something that's progressively getting worse over time and becoming more problematic in terms of functioning. You can also see some changes. We're learning more and more about sleep and dementia. And so looking at studies following people over time, that there are sometimes some changes in sleep that precede the onset. It's unclear whether that's a cause or an early sign. And
the lack of sleep, sleeping more, or just a whole change in pattern?
Daytime sleeping rather than nighttime sleeping.
Abnormalities in sleep. But I think when you get more advanced Alzheimer's, you will have more excessive sleep or disturbances in sleep that are a little different. The sort of sleep problems that precede that researchers are looking at are more insomnia. There are other forms of dementia where frank sleep disorders are more common, but in Alzheimer's, it's more of a lack of sleep that can predate it, and mood symptoms, like was mentioned too.
Yeah, and sometimes they can be up in the middle of the night where they were not a night person. So, yeah, the disease, whether it's Alzheimer's or another type of dementia, it can affect the part of the brain where your biological clock is at, and your sleep and all that is at as well.
I hear us talking about quality of life too. So it's so important to know what the cause is in terms of change in health. Is it another stage along the dementia line, or is it, we run into it with the simple urinary tract infection, and you've got someone and there's a predictable behavior as they deal with their dementia, with their Alzheimer's, and something as simple as getting a test. We know, oh, this is what it is, let's take care of that. So that person then is restored to that better quality of life.
And it's important to remember that this is a diagnosis that can only be made definitively on autopsy. And so as a field, we're moving towards more of a possible or probable Alzheimer's disease based on how much evidence there is. So you have to rule out everything else to be able to you're left with still a problem. And a lot of this is not a one visit diagnosis. It's over a period of years sometimes to actually see that progression. So in my practice, I would test people annually. And there are some people that would have some cognitive change, but it would stay very steady over time. And other people that would progress really quickly. And so you were talking earlier about the stages. The duration of the disease varies considerably. And some people will have a very slow progression across those stages, and other people it will be quite short. So families, I think it is really important to get lots of different perspectives and not assume that your loved one will have the same course as someone else.
That's right. When you met one person with Alzheimer's, you've met one person with Alzheimer's. everybody takes a different course.
Well, and in fact, patients can behave very differently. Some will get quite angry, others will laugh things off.
Hallucinate,
yeah.
so on and so forth, right.
Yeah. I also thought it was interesting with Dave that he recognized the sign and went to his wife and said, there's something wrong. I would imagine that is a rare case, though, that people don't usually recognize it in themselves.
Well, early on, I would say most people do. That's not usually when they get diagnosed. So in retrospect, you know, and I think if you catch people early enough and they're not avoiding it. So often people will recognize it, but they don't want to tell anyone. You know, he had a very open kind of view of it and is probably the exception. I think it's a very threatening thing for people.
And also a family history that
right.
he could reflect upon, too. Yeah. You know, as if, well, Grandpa had diabetes, so I'm alert to that possibility, so yeah.
What do we know about research right now? It almost is, as you mentioned, until autopsy, we don't know a lot about diagnosing, or at least definitively, that you have Alzheimer's.
Well,
so what do we
there's
know?
Not a cure. We don't have a cure yet. The medications that are there for Alzheimer's can help with the symptoms, but they don't do anything to stop the pathology of the disease. The brain continues to die even with those medications, but the medications might be able to help them with their short-term memory for a period of time. They might be able to allow them to better to do activities of daily living for a period of time. But the fact of the matter is they're on a slope downhill symptomatically, and the medication, some of the medications can help to make that a little bit more of a gradual slope downhill. You know, there are progress being made, but we're still not there yet. I mean, there are studies where they are speaking of people who are younger onset, and familial Alzheimer's, where they're giving medications in a study that will hopefully stop the increase of beta amyloid protein in the brain, thereby stopping them from getting Alzheimer's disease. But we're too early on in that study to say anything. There is progress being made, and Congress now is really beginning to put the funding behind Alzheimer's research for the National Institutes of Health.
Yeah, and I think that that's a really important point, that there are I think it was over 100 clinical trials going on right now, funded by the government for treatments for Alzheimer's. But on the other side, we are still learning about what is actually causing the disease and what leads to its progression. So there are different theories about it, but we're learning more all the time. There's a trial going on right now of inhaled insulin for Alzheimer's in Seattle. And this is because there was a newer theory that it might be due to insulin resistance in the brain. And this is a newer view that had not been the traditional understanding of Alzheimer's. So the more research we do, the more questions we have. But over time, it will lead to improvements in care for people, and I think that has been happening.
There's a human cost and a financial cost, too. The cost of treating patients with dementia and the complications that get them, you know, it's a cause of death, or a comorbid part of death that a lot of people with dementia, as was mentioned, they fall, they break their hip, then they end up in trouble, and so on and so forth. So there's a lot of...
It is the most expensive disease in America.
And even though we never like to talk financial when we're talking about healthcare, we don't have deep pockets as we perhaps used to. And
well,
so
right
we
now,
have to
$259 billion a year that we're spending on.
Right.
And we've already talked about those numbers increasing, so this is something that definitely needs to be addressed.
It's going to impact future generations. So,
What do we know about brain injury and a connection to Alzheimer's? Is there one?
So this is a very controversial topic. I think that there likely are a number of things that happen in a person's life that may make the brain more vulnerable to changes related to Alzheimer's. it's really difficult to do this research. So many people have concussions that never go on to have any difficulty related to that. Our skulls and our brains are very good at protecting and being resilient to those injuries. I think that there certainly is evidence that more severe brain injuries can increase your risk to potentially having an earlier onset of dementia. And whether it's Alzheimer's or another form of dementia is a question. And we probably all heard a little bit about the NFL and sort of different stories in the media. And I think it's really important to be sort of observing that, but not coming to any conclusions yet, because it can be really scary for people. If you have a concussion, that does not mean that you're going to go on to develop dementia. And I think that going to extremes in either direction can be a little bit dangerous.
But if you've been diagnosed with high blood pressure early in your life and you're often asymptomatic and not having symptoms from that, it's important that those things get treated, because over time, high blood pressure and high cholesterol and uncontrolled diabetes, smoking, all contribute to vascular dementia, where blood vessels are injured in the brain. Parts of the brain can be affected, and you can become demented in that regard. A lot of these there's crossovers between what Alzheimer's looks like and what vascular dementia looks like and what previous trauma looks like. Oftentimes there's many factors involved, but we certainly want to, those are things that we know we can treat and do something about, where perhaps we're not quite ready to be able to fix
and I think we
the
always
origin of Alzheimer's yet.
Yeah. And as far as the head injuries go, we always want to prevent them, for sure. But I think that there's a balance with anything, that we can't live our lives not doing anything or not taking any risks.
As the disease progresses and you get to the point where you might not be able to live by yourself or even with your caregiver, how do you make that decision? When do you make that decision to go into a facility that can help?
Well, safety is obviously a factor. Capabilities of your care partner. As you progress into this disease, you're going to need more help with activities of daily living. Trying to get somebody into a shower or into a bath, and having to, to prepare all the meals, clean the house, do all these things. You really have to think about the care partner, and is the care partner going to be able to provide all this, and take care of all of the, as I mentioned earlier, all of the emotional needs and other needs of the person. And that's really where the family's going to have to answer that question. Are there other people who can help out? Are they really going to do? We've seen people thrive in residential care facilities.
And do we have enough available, Joel?
I think we need to continue to build our capacity, because unfortunately, until we do find a disease-altering medication, those numbers of people who are going to have the disease are going to go up. Not only do we need capacity with residential care facilities, but we need to be building our capacity around support services for the person with dementia and their family members and their care partners. And we aren't there yet. We here in the state of Washington, we do have an Alzheimer's and dementia state plan, and that's one of those goals are in there, and we're working toward that. But we need to address this tidal wave.
Before it becomes catastrophic, as was mentioned before, so many of these people get into a hospital situation, and we find out that their care partner is in a wheelchair, for instance, and is not going to be able to provide the support that this individual needs now that they've had a broken hip. And that's when they go looking for assisted living or a nursing home facility. So if we can anticipate some of those in advance, we might be able to prevent some of the traumatic events that occur, and also plan ahead for where the individual may end up.
Well, it's even more problematic in our rural communities, which is another area that we're trying to plan for and think about, because residential care facilities, well, those are few few and far between. Try to get an in-home caregiver to help out and give some respite, or there just aren't the adult day health or adult day care facilities in Davenport or other.
And Barbara, I know you have some real concerns about doctors being trained. There aren't really Alzheimer's doctors per se.
No.
And I know that you're concerned about that as we move through the next few years.
Right. Because I would look first toward gerontologists, but with baby boomers coming in, and we were, Steve and I were talking a little bit too, and in terms of making sure that these doctors have some training, because they are going to be the front line in determining care or referrals out. The other folks that need training are the caregivers. I think there is a shortage of caregivers, period, but then there are special needs for those who are caring for folks with Alzheimer's or dementia. Yeah.
And that's where the school comes in.
And that's where the school comes in. So we're trying to project where we're going to be 5-10 years out. What are the needs of the communities, especially the rural and the underserved, where they don't have the money to hire caregivers. There aren't, as mentioned, there aren't assisted living centers in a small town. We've had this issue with some rural palliative care issues that we've taken care of. How do you get services out into the community? And telehealth and telepresence will probably be part of that. We're going to have to be very creative, both from a financial standpoint and from a manpower standpoint, how we're going to offer those services to the masses, because as the numbers increase, they're not all going to have the availability. So at the very least, whether our graduates go into primary care or surgery or wherever they go, they need to be humanistic. They need to be compassionate. They need to understand the breadth of the care of somebody who's aging, and whether they're there to operate on their broken hip or whether they're there to take care of their heart failure. They need to look holistically to try to decide how we're going to best serve our aging population.
Well, they have to point people to the local services like the adult day health. Sometimes it's, okay, the diagnosis is Alzheimer's, now what? And we'll see in 3 months.
To solve that problem, right?
Yeah.
You are going to be able to help us with that problem.
Yeah.
And I think that I know that there's research going on down in Pullman at WSU around some sort of innovative strategies for helping people stay in their homes when they may not have caregivers. So smart home technology where sensors can detect if someone's been taking their medications or hasn't opened their fridge in a day, so that can then notify a physician somewhere else that someone can be sent to check on a person. So these kinds of strategies to think outside the box and be able to help more people are going to be important, but you're still going to always need that human connection as well.
Well, and because our families are more spread out than they ever used to be, families aren't quite as connected as they used to be, those kind of technologies could really make a
life-saving.
Could really make a big difference.
There are services where, right now that are available that you can have video cameras in their home, so someone can watch their mother while they're at work and see if anything's happening that they need to attend to. So we're there.
Well, and can tell you whether or not they're taking their medications or whether they've eaten today or. Yeah.
Well, as we get closer to the end of the program, I guess I'm interested in maybe some final thoughts. It is a big topic, and we have tackled a lot tonight, but maybe some final thoughts on Alzheimer's and where it's going and what you would like to see people address. And Barbara, I'll start with you.
I think the thing that's important for me is the interweaving of so many support services, that the family's not there alone. The caregiver needs the support services. The identified person with the dementia needs support services. And they cannot be done in isolation. It really has to be a whole woven thread, and working toward that, I think is a really worthy goal.
Dr. Grossman.
I agree Completely. I think one of the things that we can begin to do is have those conversations, as I alluded to earlier. The National Hospice and Palliative Care Organization said when families get together, for instance, during holidays like Thanksgiving, it's probably a good time to begin to have some of those conversations where you don't want to be cutting the turkey and asking mom what nursing home she wants to go into.
But everybody's there.
But everybody's there. And so perhaps over those couple of days where families reunite from around the country, you can begin to address the obvious things. Well, what would happen if mom all of a sudden got to the point where we didn't feel that her safety at home alone was reasonable? And if we can open the doors to some of those conversations, they certainly it would certainly help the conversation and help the health care of the individual and the whole family. And I think that the support of the patient is invaluable, and making certain that we've trained the caregivers and found enough of them, because the task for most families is overwhelming. And if I take a day off to stay home with my loved one who can't, care for themselves, then there's lost productivity on my end, and on and on and on. And so it becomes a very difficult situation that we all need to work hard to solve.
Joel?
Diagnosis, find out what's going on. Try to do that sooner than later. I agree with my colleagues that they need to seek out services. And keep in mind, you eat the elephant one bite at a time. You don't have to go out and solve all of the problems all at one time, but don't procrastinate, and start sooner than later.
Okay, Dr. Chaytor.
I think that I would really encourage people to think about their cognitive health as one other aspect of their health, and to get it checked up.
Just like you would anything else.
Exactly, and talk about it with your doctor. Is this normal? Kind of track things over time, and if you're concerned, the earlier the better. And it's not something to be ashamed about, embarrassed about. It's a disease like anything else, and most of the time you're going to be reassured. And I think that's something that's important to keep in mind with all of this, that I spent much more time telling people, like, no, this is normal for your age. You're doing great.
That's
Keep
a
it
very
up.
good place to leave it. And thank you all. If you are in need of resources, we have several that we want to share with you tonight. First, the Alzheimer's Association has a toll-free helpline that is open 24 hours a day, 7 days a week. That number is 1-800-272-3900. If you're in Canada, call the Alzheimer's Society of Canada. That helpline is 1-800-616-8816. There are also support groups and classes available. To learn more, please go to our website, that's ksps.org, and click on Health Matters. And that will do it for this edition of Health Matters. We'll be back next month when our topic will be lung cancer. We'll bring you groundbreaking research going on at the University of Washington.
In patients with advanced stage disease, can we treat their cancer with vaccines, and can we prevent their disease from coming back? And the results of those phase 2 studies are very encouraging.
And that is coming up on May 17th. We hope that you'll tune in then. Until then, I'm Teresa Lukens. Good night.
Health Matters is made possible by our viewers, the Friends of KSPS, and by Providence Healthcare.
I'm Arnie Peterson, and I'm an orthopedic surgeon, and I work at Sacred Heart for Providence Medical Group. When I needed my hip replaced, I chose Providence because of the professionalism and the care that I knew I'd receive. I never thought twice about going anywhere else.
My name is Beth Torres, and I am a registered nurse, and I work at Holy Family Hospital on the labor and delivery unit. I'm about to have my second child, and I chose Providence because I love and trust the people that I work with, and why wouldn't I seek care from people that I love and trust?